Sponseller. I'm a technical veterinarian for Boehringer Ingelheim Stop Rabies program. So thank you for joining me this afternoon for this United Against Rabies webinar entitled Eliminating Dog-Mediated Rabies, Addressing Barriers to Scaling Up Dog Vaccination Campaigns. So today's webinar will start with a short presentation on dog vaccination, and then we will proceed to a panel discussion with our other featured guests. Just as a quick reminder, we have both the chat functions and the question and answer functions available for this webinar. If you'd like to introduce yourself or make a general comment, then please feel free to use the chat. And if you would like to address a specific comment to one of our speakers, then please put that question in the question and answer box, and it will either be answered live or we will answer in written form. But one way or another, we will address your question. So to begin, I would like to introduce Dr. Elly, who is the director of ICAM, the International Companion Animal Management Coalition. And Dr. Hiby's here to present the Dog Vaccination Barriers and Solutions document, for which she has been the primary driver. So Dr. Hiby, over to you.
Thanks, Jerlyn. I'm just going to set up my slides. Okay. Thank you very much, Jerlyn, and thank you to all of you for joining us today. I'd also like to start by thanking the members of our work stream. Their names are all displayed here on the slide. And also thanks to the UAR network in general for contributing to this piece of work. And thanks to my co-lead, Dr. Maganga Sambo, who you'll be hearing from later today. It was actually Maganga's observation that was a key inspiration for this piece of work. He recognised that the challenges facing those aiming to implement dog vaccination to sufficient coverage and to sufficient scale to eliminate rabies were repeated across the world. Now, that's not to say that every country or every community has the same barriers, but that it's very likely that when you come up against a barrier in dog vaccination, someone somewhere will probably have faced the same barrier or problem as you, and hopefully has found a solution to overcome that barrier. So if we can create and keep developing a home for these solutions, then we can support those in the wider dog vaccination community to move forward at greater pace. And if we find a barrier for which there is currently no obvious solution, well, then that's a great place for members of the UAR forum to focus our efforts in finding new solutions. So we started by looking at the outputs of a previous UAR workstream called the Constraints Workstream. They had been tasked with a scoping review of the available literature, looking for what constraints to rabies elimination were described. And constraints were defined as barriers which, despite the general knowledge of measures to be taken to eliminate dog-transmitted human rabies, prevent countries from successfully implementing these measures and progressing towards our goal of 0 by 30. And they found many constraints described, and they fell into these 11 categories. And one of the biggest categories was this one, dog vaccination. And so this is where we focused our efforts. We started by pulling out the barriers they had identified from the literature. We removed duplicates and we added barriers that we thought had been missed. So those were things that we had experienced in the field and knew others had experienced, but were unlikely to make it into a publication. And we came up with a list of 23 barriers. We then went out with an online survey to ask others in the field about their experience of barriers. We wanted to hear from people that had themselves managed, worked on, or evaluated dog vaccination campaigns. We started with the members of the UAR forum and used a snowballing or network approach. Each respondent was asked to forward the survey to other colleagues that had this same background. So our survey started with some simple questions about the characteristics of the vaccination campaign they had worked on, where in the world this campaign was held, who was the lead body, how many dogs were vaccinated, and what vaccination strategy was used, central point, door to door, and so on. But most importantly, we asked respondents to tell us how important each of these barriers were in their campaign, and also if we'd missed any barriers in our list. And a big thank you to any of you that contributed to your thoughts to this survey. We had 146 respondents reporting on vaccination campaigns carried out in different countries from across the world, more from Africa than any other continent. And this was the final prioritisation of barriers across all respondents, with the lacking access to estimates of dog population size at the top and a lack of trust in vaccinators at the bottom. We looked at vaccination campaign characteristics and found some variation in which barriers people prioritised. For example, the top priority varied slightly across region, with lacking data on dog population size being a priority in South Asia, in West and South Africa. But in East Africa, more people reported weak infrastructure to be the top barrier. Whilst in Southeast Asia, owners not bringing their dogs for vaccination because the distance to vaccination points was too great was described as a top barrier. Over in the Americas, it was insufficient vaccinators as the top priority for North America, and dog owners' lack of awareness of when and where vaccination campaigns took place topped the list for Latin America. Now, some of this variation between regions might be due to using different vaccination strategies. For example, those using central point were more likely to cite distance to vaccination points as a barrier than those using mobile vaccination points or indeed door-to-door strategies. Scale and stage of the vaccination campaigns was also relevant. So where mass dog vaccination was still in its early stages of preparation and scaling up, described as stage 1 and 2 by the Global Dog Rabies Elimination Pathway or GDREP, lacking estimates of dog population size was more likely to be a priority. But in the later stages of sustaining vaccination coverage, the barriers were more likely to be related to low public awareness about the importance of vaccination to prevent rabies, or lack of community engagement or attendance at mass vaccination campaigns. Now, despite these examples of variations, we actually also found a lot of consistency on what people felt was important, with the same few barriers always appearing near the top. The next step was then to start searching for solutions, again starting with our workstream and their colleagues, and then using an online consultation event across the wider UAR network, and always asking people to search beyond their desks and reach out to colleagues for their identified solutions. We were not looking just for peer-reviewed publications, but practical tools, learning points, and policies that people had found really helped their vaccination campaign succeed. We were conscious that the people that would know the answers to these barriers were not the general public. We needed to search out a very specific community of people, and we are eternally grateful for those who came forward to tell us their experiences. The process of identifying solutions allowed us to refine our list of barriers, redefining and combining some of them to create a shorter, prioritised list of just 9 barriers that fell into 3 broad categories of estimating dog populations and coverage, campaign engagement and outreach, and campaign capacity. And for these 9 barriers that you will see in black at the top and the bottom of this image, we identified a total of 30 solutions, which you will see in the blue boxes. Each barrier is linked to at least one solution, but actually usually more than one. And for some solutions, they are linked to more than one black barrier box because they can be useful for overcoming more than one barrier. Now, this is quite a busy slide with necessarily small font to fit all these solutions onto one slide. so I do not expect you to be able to read it all here, but know that the full document is available now to download from the UAR website. Now, hopefully, the UAR website is a familiar place to you all. If you check the resources tab, then go to UAR best practice, you'll find plenty of useful resources, including our new dog vaccination barriers and solutions document. So once you're into the document, you will find an explanation of each barrier and then a list of potential solutions. If there is a solution here that you want to learn more about, click the hyperlink and you'll be taken to the right point in the solutions section of the document, where you'll find a more in-depth description of that solution, including links to further resources that you might find helpful for implementing the solution. I do want to emphasize that this is version 1. We are committed to updating this document over time, and we actually already have some solutions that are in the initial stages of testing and launch, and we hope to add these to version 2. So to that end, in the introduction, you'll find a link to a feedback form where you can tell us your thoughts. Have we missed a barrier that's important to your campaign progress? Or do you have a solution that you want to make others aware of? Please let us know. We are all ears. And that's it from me. Thank you for your time. And I'll hand you back to Jerlyn for our next speaker.
Thank you very much, Dr. Hiby, for presenting that very, very useful document. So I would like to ask you to stay on screen so that you can join our discussion. And then I'd also like to introduce our other speakers. So joining us today, we have Dr. Maganga Sambo, who's a research scientist at Ifakara Health Institute in Tanzania. So Dr. Sambo, please feel free to turn on your camera. And we're also joined by Dr. Sambo's colleague, Dr. Tetteh Duamor, also from Ifakara Health Institute. And Dr. Tetteh Duamor has a background in epidemiology and infectious disease control. Then we have Dr. Martin Barassa, who is head of regional programs in East Africa for VSF, Vétérinaires Sans Frontières, Germany. And finally, we have Dr. Fred Lohr, who's the Director of Strategic Partnerships for Mission Rabies and Worldwide Veterinary Services. So thank you all for joining today. So Dr. Sambo, I'd like to start with you. You have a lot of background in estimating dog populations for mass vaccination campaigns. And so I would like to ask you, when planning and executing one of these mass dog vaccination campaigns, what do you do? How do you best execute and plan when you are missing that crucial information on the size of the dog population?
Hi, thank you, Jerry. Hi, everyone. Sorry for my internet, but I will respond to this question. As you've seen from Elly's presentation, most of responded from Asia and Africa reported that dog population estimate was a challenge, was a barrier. And this is because we don't have dog sensors. But compared to other countries where their dogs are registered, they have a good data on dog population estimate. But for Africa and Asia, because they don't have dog registration, they don't have estimates. So we need the dog population estimate for two major reasons. The first reason, you need for when you are planning for campaign, you need to know how many dogs you need to vaccinate. And this is very important so that you can estimate how many vaccination consumable do you need, like how many dog vaccine do you need, how many syringe and needle do you need, but also how many dog vaccinators do you need to cover or to vaccinate all those dogs? And another reason to have dog population estimate is to assess the effectiveness of the campaign, at least to know the coverage that's achieved for the campaign. So this has been reported as a barrier, but this can, to my experience, this cannot stop for the campaign to start, because we have the human-dog ratio. And why do we have human-dog ratio? Because there is a relationship between human and dogs. So wherever there's human, but there is also dogs, are the people who own dogs. So by having the human-dog ratio, and we have a well-established, and from this solution that if you peruse for it, you will see a human-dog ratio to various locations. So human-dog ratio has been a good starting point, so that you can estimate and get a picture at least how many dogs do you have. And the good thing about human-dog ratio tended to overestimate the number of dogs. And then you won't learn out of the vaccine if you de-estimate the number of dogs based on human-dog ratio. So this is very useful, and then you can start. But when you start implementing the campaign, and then you start to refine dog, or you use to refine the number of dogs in your community. Thank you, Jerlyn, for now. Hand over to you.
Thank you, Dr. Sambo. So, Dr. Tetteh Duamor, you have experience with engaging communities to increase participation in mass dog vaccination campaigns. And so I'd like to ask you how you use community engagement to address barriers to participation, to get more people in the community involved at the grassroots level for these vaccination campaigns for dogs.
Yes, hi everyone, and thank you for having me. Yeah, so before I start, let me say that the perspectives I'm about to share are more from implementation science point of view than implementation practice, because our team in Tanzania is still trying to answer the question of how mass dog vaccination campaigns can be delivered and how these barriers can be addressed. Then also to further put the conversation into perspectives, I would like to remark that insufficient dog vaccination coverage is basically a thing of developing societies. And it doesn't matter where these societies are, whether in North America or Southeastern Asia or in Africa. There are certain socioeconomic factors that leads to people not taking proper care of their dogs, and hence least participation in mass dog vaccination campaigns. So from our experience, if you try to match the efforts implementers are putting into vaccination campaigns, for example, the amount of advertising they are doing or the number of days of vaccination campaigns, it doesn't seem to match the outcomes, the vaccination outcomes that they are achieving. And that suggests a huge role of moderating effect of contextual elements in determining the outcome of vaccination campaigns. So aside the other factors or barriers that were identified, we also encountered some, and we have tried to address them in several ways. First of all, the issue of limited opportunity for vaccination, because in Tanzania, vaccination campaigns are organized once in a year. The population virtually have limited opportunity to assess dog vaccination campaigns. So we have been trying an extended vaccine distribution system where we are using a passive cooling system, which doesn't require electricity to store the vaccines in remote communities. And we have built a vaccination strategy around it, where the vaccinators are to organize vaccination campaigns 4 times in a year. And then in between those campaigns, they have to systematically search for dogs that missed the previous campaign or new dogs that were acquired. And then target these dogs in the next round of campaigns. And then also in between the campaigns, there is the opportunity where the vaccinators they make their telephone contacts available, so the dog owners can contact them each time they have a new dog that needs a vaccination. So this is one way that we are making vaccination services more available to the population to ensure that they have more opportunity to have their dogs vaccinated. Then there is the issue of limited reach of the advertising campaigns. If you have a vehicle mounted with a speaker going through the central routes of the village and advertising, our experience is that from some of the responses from our research is that people, especially those at the periphery of the village, don't get information. And so in one of our papers that we published, if you look at the reasons people give for not vaccinating the household dog, it's either the dog owner is not available or was not informed about the vaccination campaign. And that accounted for 40% of the reasons for not vaccinating the household dog. So we are now using a village-based person who uses a megaphone, and either on foot or on bicycle or on motorbike is able to access most of the houses on the fringes of the village. And so there is the heightened awareness of the vaccination schedules. Again, the issue of trust in the vaccines. In the course of our research, we noticed that we were picking the signals. People were like, well, if you vaccinate, your dog is going to die. It may develop skin rashes. The dog might become infertile or docile. And so we decided to do a small community engagement to see how widespread these perceptions are. And we found that out of more than 700 respondents, just about 8% of them express any form of these reactions. And the engagement activities really did not work to change these perceptions. And we think probably it's because these are perceptions that are held by just a handful of the population. But then we made observation that if these perceptions are held by key figures in the population, they could have influence on other people. But also it's because these perceptions may have been held for a long time, and it will take people actually vaccinating their dogs. From the observation again, we saw that once people vaccinated their dogs a few times, they begin to brush aside those kind of perceptions. But then there is another observation regarding trust in vaccine, where you will meet the vaccinators, somebody who has a diploma in animal health service, tell you that the first time we vaccinated the dogs, a lot of the dogs who had rabies died. So that is to say that if a dog had rabies and a dog is vaccinated against rabies, the dog will die. So that's a key perception that needs to be tackled. This particular one is something that we have noticed afterward, and going forward, we'll see how we can diffuse that with education and community engagement. But also, it's something that goes to support the fact that adverse events after vaccination should be investigated to inform how the outcomes can be incorporated into engaging the communities. So we also notice a lack of knowledge of dog behavior among the vaccinators as well as the dog owners. And this results in people's fear of their dogs' inability to restrain and bring their dogs to the vaccination centers. At the vaccination centers, you saw the way dogs are handled. Sometimes somebody might approach the dog with so much force that the dog begins to struggle. There's also the issue of appreciation of lack of the importance of vaccinating dogs. You will be, through our observation of advertising of the campaigns, you are advertising a free vaccination campaign, and then somebody is asking you, why don't you provide vaccination for goats or cattle or other animals? Then also there's a mixture of low perception of the risk of rabies. You have people who think that the risk of rabies is quite removed from them, and so they are not interested in vaccinating their dogs. But on the other hand, There's also people who have intense fear of rabies and hence dog bite, and so they don't want to have anything to do with dogs or taking their dogs for vaccination. So through our community engagements, we analyzed the results and saw that the community engagement actually impacted people's knowledge and their behavior towards dogs. Then, with respect to trust in the vaccine, we try to involve the people in the process, in the planning and the delivery process. We also try to select the right kind of mix of leadership of the campaign at the level of the village, because in the context of Tanzania, at the level of the village, you have about 3 different types of leaders. And if you leave one out, you might be in trouble. Also, if you select the wrong person, you might not get the right kind of response. There's so much to be discussed around this point. But also what we did, or what improved, what addressed the trust in the vaccinators. Let me say that the trust is, from the point of view of vaccinators, the dog owners, it's about motive. Motive, why are people trying to enumerate dogs or try to vaccinate dogs? That is their motive. And they might be wondering that, they are trying to enumerate dogs so that the government could come in to tax them. But from the point of view of the vaccinators, the trust deficit from the community or the other leaders who are supposed to give them support is of financial and political. Financial in the sense that other people see them as having, they are benefiting from the program. So if they are going to give them support, then they should also have part of that financial benefit. But also there is the kind of people wanting to take political advantage of the campaign. I mean, who is going to get a political credit for? And so based on that, people actually doubted what purpose or who is behind this and all that. So the use of local people at the level of the village to support the campaigns help in a way to gain some acceptance. And also in a broader perspective, the use of local people, is a bit more less expensive. And also these people, they know the terrain and they are better able to maneuver in terms of, for example, they know where wildlife is, and they know when and how to avoid, human-wildlife conflicts, or when to find a particular group of people in a community and all that. But more importantly, the use of local people has the potential to actually help to properly situate the campaigns around the socio-economic activities of the people. Because if you are conducting campaigns, and that is one of the key observations we made, that people were not participating because the campaigns actually mostly conflict with other activities. And in the context of Tanzania, just before I end, if you are looking for people to participate or a schedule that works for most people, then you should be looking at just after the end of the farming season, when people are just not too busy and they are waiting for harvest. Around that time, the environment too is not too dried, and the livestock keepers have now also started migrating in search of greener pastures. Once it is outside of the peak of the rainy season, then places or the roads are become more motorable, and so it also helps. It should be also outside of when people are in school. It should be outside of other national activities, because we saw that when there's other national vaccination campaigns or elections and other things, it tends to affect the vaccination participation in vaccination campaigns. Then it should not conflict with cultural activities. If it does, you can be sure that people will neglect the campaign. Thank you for now.
Thank you very much, Dr. Tetteh Duamor.
You're welcome.
Now, Dr. Barasa, you have expertise engaging with community-based animal healthcare workers, and I would like to ask you how you would suggest it's best to navigate the legal structure to allow animal health workers to participate as dog vaccinators in dog vaccination campaigns, given that most of these animal health workers are lay people and not veterinary professionals.
Okay, thank you very much. Let me start by saying that as an organization, BSF Germany has been involved in rabies vaccination campaigns since 2015. Between 2015 to 2020, we mainly focused in Kenya, but since then we have expanded to South Sudan, Ethiopia, and Uganda. And the issue or the barrier relating to insufficient trained personnel is a common barrier that we do encounter in these countries. The issue of CW legal status, of course, is a thorn in the flesh in the Horn of African countries where policy and the regulatory framework applies differently, and some countries have allowed them to be integrated in the National Animal Health Service System or the national veterinary structures. Others have restricted to the extent they can be deployed or used, while others have outlawed. Now, the perspectives I'm going to share will be varied based on the experiences we have from the different countries. But let me start by saying that the fact that sometimes regulations is a limiting factor to their deployment and use in carrying out vaccination campaigns, this has not been an excuse or a reason for us to drop the campaigns. There are a number of measures or strategies we have adopted to overcome this. And one of them is to collaborate and partner with the local veterinary authorities in the planning for the veterinary campaigns. In countries where, for example, CWs are allowed to operate by law and by policy, it is a very straightforward matter. And for us, in the case of South Sudan, where this is applicable, when we are planning vaccination campaigns in areas we have mapped and identified as hotspots for targeting, it is very easy to mobilize and constitute CW teams, train them and teach them and facilitate them to engage in dog vaccination campaigns. And this has been very possible to help us realize significant achievements with the outcomes of the campaigns. When you come to countries, for example, like Kenya, where the use of CWs is limited, actually outlawed by local regulations, you may not even mention them. In fact, the use of the term CW is not even there. They have since been redesignated as either community disease reporters, or in some contexts, they are called community health practitioners or volunteers. But what we do now is to engage in a discussion with the county veterinary authorities in the counties that we target, and where you find some people who had earlier on, before these regulations came into force, had been trained as CWs to still be able to participate. This is based on professional compromise and some mutual agreement to allow these cadres to still participate. And there are a number of factors which favor their participation and which therefore motivates the county veterinary authorities to compromise on their involvement. One of them is that these community animal health workers, though they don't use that term here in Kenya, they call them disease reporters, have got very good knowledge of their respective context. And mostly you find them in very remote and hard to reach and underserved areas, for example, in Marsabit or in Turkana or in Narok or Kajiado counties or Machakos. And so they have a very good knowledge of their respective areas. They know the people, they know community members who own dogs. And based on that knowledge, they are very handy when you are planning for community mobilization and outreach targeting to mobilize people to respond to the planned vaccination campaigns. Number two, apart from just knowing the people, these cadres also are very helpful when it comes to dealing with the dogs which are not confined. Mostly in communities, what we see is that most of the dogs are stray. They have owners, but they are roaming and are very hard to find or to capture during vaccination campaigns at the designated sites. The use of these cadres is very helpful to do traceback, especially for the ones they know who are not presented by their owners in follow-up, mop-up exercises, make sure that the level of coverage can be enhanced. Number three is that these community animal health workers, before we engage them disease reporters. There is a program for training to equip them with the necessary skill sets that enable them to support these campaigns. So there is a bit of motivation also in the respect that they benefit from trainings, and these trainings help them to acquire the relevant skills and techniques in supporting the process. For example, dog handling techniques, and also community dialoguing techniques, which are very necessary to motivate community members to turn up for the vaccination campaigns. I must also say that they are also very useful as a matter of a key factor here, that in some of these remote, hard-to-reach areas, you hardly find professional vets or vets who you can engage. And in that respect, they are very useful in some parts of Uganda also where we work, in some parts of Ethiopia where we also work, and South Sudan. Now, number two is that if for any reason the local veterinary authorities are not comfortable to allow the deployment and use of these CWs to perform dog vaccinations, then we still compromise to embed them in the teams, but are then assigned tasks which are relevant to their skill sets and which are allowable and acceptable for them to perform. These tasks basically would include community mobilization, community dialogues to wake up people, to motivate them to present dogs for vaccinations. They would also be useful in, for example, helping to capture and restrain the dogs. And in some extent also, if you find some who have some basic literacy, they are also very good in keeping records. But they are also used in follow-up monitoring. For example, if we are doing vaccination in circles, then they are useful in tracking those who presented dogs in the previous year or in the first cycle, ensuring that a turnout for the second and subsequent cycles is achieved. Lastly, let me also say that VSF Germany, we are a member of VSF International. And VSF International, in the recent times, since 2021, has engaged in a collaboration agreement with OA. And this collaboration, of course, is benchmarked on the complementary commitment to enhance the delivery of animal health services to our communities in contexts which are remote, are underserved. And through this collaboration, there has been some lobbying and advocacy with the donors. And in most recent times, the VSF International umbrella network has secured a project funded by USAID and BHA to support a project aimed at strengthening the enabling environment for CWs through the development of competency and curriculum guidelines. Now, this is an ongoing effort and initiative, and it is expected or can be expected that when it is finalized and endorsed and approved by the member states, we can engage in a campaign to encourage the uptake of this competency and curriculum guidelines for the training of CWs. It provides a clear opportunity to futuristic recognition, regulation, and integration of CWs into the animal health systems. So we do acknowledge these limitations imposed by country-specific policies and regulations. We also do have some strategies to work around them that is based on professional compromise and mutual agreements. But currently, we are also engaged in this effort, lobbying with the donors and also working in collaboration with OA to get an enabling environment through this review of training programs to create competency and curriculum guidelines that can be acceptable, allow for the deployment and the use of CWs. Over to you.
Thank you very much, Dr. Barassa. Dr. Lohr, you are an advocate for digital data collection. So I would like to ask you, why should we make this investment in a mass dog vaccination campaign when there are so many different details to keep track of? What is the benefit to digital data collection, particularly when previously it's been sufficient to record on paper?
Thank you very much, and thank you very much, everyone, for having me today. I think, Jerlyn, the partial answer is actually in your question. There's so many details to keep track of. And I think, yeah, you've taken everything out of what I wanted to say. So there's so many details to keep track of, and actually digital data collection makes that so much more easy than it was in the past. I think in particular, we should keep our eyes on the goal, on the aim here, and that is mass dog vaccination. So we do need to run pilot programs in order to test our logistical prowess in certain areas, in particular in countries. But I think the most important thing is we do have the tools and we do have the broad methodology at hand, and we just need to fine tune it and adjust it to areas. And that's where the barriers document is coming in as well, and very important, because it actually lists and shows where you can plug those little gaps for localization. Now, when it comes to digital data collection, a digital data collection tool can be absolutely crucial in collecting this sort of lack of initial data that we've heard so much about in both the chat and from all the previous panelists. And as Dr. Maganga said, the lack of such data shouldn't stop us getting started. But once we're starting, we actually want to get that data in. And that's where a digital data collection tool and the UAR toolbox has quite a few of those listed there, where digital data collection and management tool can really make a massive difference to get that data in and then refine our campaign strategy. I think what is often overlooked is this sort of refinement step. It's not just about collecting this data, it is about actually looking at the data as well, and then taking the right conclusions from the data that we have. So in particular, if we're looking at the scalability or the next steps following a pilot campaign, when we're looking at the data, so for instance, we've done this in multiple locations. One would be a published study that we have done as well, was to reduce the days of very expensive door-to-door vaccination in an African urban setting by collecting the data, placing static points accordingly, and actually achieving similar vaccination coverage by completely reducing door-to-door and replacing them with the cheaper static point vaccination. And equally, we've seen a lot of, I've been monitoring the chat. That's the great thing about coming last. You can actually already see what sort of question, what the general gist is as well. It's getting this data in through pilot campaigns really helps us to refine all of these factors, whether that is human to dog ratio, whether that is our vaccination coverage, ownership practices, etc., because we have that sort of flexibility through digital data collection to adjust our approach and our collection as we're going along. And we can collect the data, very targeted data in near real time that will help us to manage and to direct the campaign on the go. So what we've seen in particular in India, for instance, and also in Cambodia, where we have been working for multiple years now. And in Goa State, for instance, through the employment of digital data collection, it helped us to engage the communities, it helped us to engage the local government and stakeholders, and it also helped us to actually ensure that we do have a coherent and homogeneous coverage throughout the area to break that disease cycle. So it was great when Rabies State was declared the first rabies controlled area in India. And these sort of creation of success stories then help to build on this very important work. So what we've now seen, other states have taken up a similar approach, also with the digital data collection, because that just helps to direct the resources accordingly, and it helps us to refine the program. When it comes to sensitization, we've heard some excellent interventions earlier from Christian. The sensitization approach is also so underrated in a lot of campaigns, and through digital data collection, actually, as we are vaccinating animals, we can also collect data on how the communities, for instance, have heard or not heard about a campaign, and on the go, get that data in and use that to adjust our approach accordingly, tailored to individual communities. But the great thing is we can do this at scale. And again, if we want to scale up as well, we do need to engage all the different levels within a country as well, whether that is the government, whether that is local authorities, but also an approach that we have seen that works really well is engaging the local NGOs. They often have a lot of ground knowledge, a lot of data is often already out there. It's just not being collected centrally, and it's just not accessible to people in a decision-making position. So when we want to look at digital data collection in the context of rabies as well, we have to see that it's not just an investment into rabies, but implementing digital data collection in the animal health sector is an investment not just in rabies, but in other diseases as well. That's these sort of collection applications and creation of databases can then be used to collect other animal health data, similar to what our human health colleagues are already doing on a regular basis. So it will help the animal health sector as well to align more closely with the human health sector, look at that data in conjunction with the human health data, and interlink, in the spirit of One Health, interlink the two sectors more closely as well. What we've seen in other areas as well, in other areas of the world, where we do see bigger progress in rabies elimination, like in Latin America, for instance, we have seen that the human health sector is actually, the public health sector is actually taking the lead there as well. So through the provision of better and more detailed data, we can hopefully get this sort of, create this sort of leadership in all the other endemic areas as well. And finally, move forward to the national scaling up of these pilot campaigns. Thank you.
Thank you, Dr. Lohr, for your perspective and particularly for bringing some insights from your work in Asia. So, Dr. Hiby, I'd like to bring you back into the conversation and ask, in your experience, how variable is the dog-to-human ratio for population estimates, and what factors contribute to this variability?
Sure, I can make a start of that, and we might find that Maganga wants to add a little bit, because I know this is an area he's worked in as well.
That's great.
But just to say that we address this a little bit in the document as well, so I'll speak to it a little bit now, but do please check out the document for the section that talks about this in more detail. So we've provided some regional estimates of human to dog ratios, which, I mean, there is a significant difference in the ratios across different countries, different continents, different regions. So we've provided what is published as a foundation to start from. But even taking those ratios within a country, you then also see a lot of variation between communities, and there's a couple of variables that are good predictors for that. And one is human density, and the other is religion. So in cities that have a really high density of people, you'll find that the number of people per dog is much higher, and therefore the number of dogs that you find in those high density cities are going to be lower than what you would predict from the national average ratio. And in the opposite direction, in very sparsely populated rural areas, you're likely to find more dogs than are predicted by the national average of human to dog ratio. And we provide some examples of published data in the document, so do take a look there. And then layered on top of that is then the religious background of the people involved. So in those communities that have a large proportion of Christian households, they tend to have more dogs than those that are those communities that are predominantly Muslim households. And again, we've provided a little bit of data on that in the document to give you an indication. Now, this is just the way to get started, using those published ratios and varying your estimate according to human density and religious background. You should then be able to come up with an estimate for your area. But of course, the best thing you can do is to go out and actually start vaccinating, and then use those post-vaccination campaign surveys to refine your estimate going forwards. So every time you've done a vaccination campaign, you're going back out and using a combination of the street surveys and household surveys to try and see what vaccination coverage you've achieved. And that's a great opportunity to refine your estimates, because then you can see, actually, I vaccinated this many dogs, but what does that represent in terms of the proportion of the population?
Thank you. Dr. Sambo, would you like to add anything?
Yes, yes, Dr. Jerlyn, I would like to add something. Another good predictors that we found is livestock ownership. We find that the household that they tended to own livestock, they tend to have more dogs compared to the household that they don't have, they don't own livestock. And it probably also is highly correlated because with rural, because we find most of the livestock keepers are in rural areas. But and these livestock keepers, they tend to own dogs so that they can protect heading their livestock, but so that they can protect their livestock against wild animals. So that is another predictor for dog ownership. Over to you, Dr. Jerlyn.
Thank you, Dr. Sambo. And then back to Dr. Tetteh Duamor, a question about encouraging dog owners to have their dogs vaccinated. What do you suggest in terms of really trying to increase community participation in the actual vaccination events?
Thank you for the question. Yeah, so in the attempt to encourage participation, I think we should basically look at the factors that are preventing people not to participate. And so if it is about people not getting information, or it's about people, not wanting to pay for vaccinating the dogs, then we tackle those fundamental challenges. And so one way, in the context of Tanzania, and probably in most of sub-Saharan Africa, we can actually work towards ownership of the vaccination processes by communities. And so it comes back to the question of engaging communities to actually fully participate in the process of the vaccination campaigns. And that would go a long way to address some of the challenges. For example, if we engage communities deep enough, and there's a possibility that we have communities participate in the planning, the implementation, and the evaluation of or monitoring of vaccination activities at the community level. And again, in the context of Tanzania, if we successfully have community leadership monitor the vaccination campaigns, that potentially will encourage ownership, because we are talking about a community leadership that has a lot of authority. People have respect for their leaders, and they have the community structure or leadership of the Tanzanian community actually have a huge amount of agency, and they can actually enforce and ensure that people participate in vaccination campaigns. Again, if we engage communities enough, there's a possibility that the communities can actually incorporate vaccination activities into their annual calendars. In the context of Tanzania, there are certain activities that the communities do that are kind of, they recur, and usually the community members respect these calendars. So if you have mass dog vaccination campaigns as part of their annual calendar, it becomes easier. People know that in these particular days, in this month, we are going to vaccinate our dogs. And that also helps people to plan all the other activities in that month around the vaccination campaigns. And then also you can have community people actually participating in the process. For example, if you look at the fact that if you take out the cost of vaccine and other things, what the cost that goes into the actual delivery of the campaign at the community level is basically, it goes to human resource or the team that is delivering the campaign. And so you can have a community-based person do rabies education. If somebody is trained, probably through a train-the-trainer model, you can have somebody at the village level who constantly educates the people about rabies in their community meetings, and that will help to bring rabies to the forefront. Again, we need to have people to participate, I think we need to build community dog registries. And again, in the context of Tanzania, you have a community structure that is quite elaborate. Villages divided into sub-villages, and those sub-villages are further divided into units of houses. And all these units have leaders. And already they have some form of responsibility even towards the veterinary system in accounting for a number of other livestock in these units of houses. So we can just incorporate these kind of dog sensors into that. And so we know where the dogs live and who owns them. So for example, in our continuous vaccination strategy, when the vaccinators are trying to find out which dogs made the previous campaign, it becomes a challenge because now you have a very wide community setting and you have to just go blindly, find dogs that were not vaccinated and you don't know where they are and who owns them. But if we have a community dog registry right at the vaccination center, I mean, that are linked to the households and the names of their owners and all that, you know, during the vaccination campaign, the person comes, you open the register and you look for the dog's name. The dog is vaccinated, it is ticked. And so right at the end of which households have dogs that were not vaccinated. And then it helps to quickly calculate your coverage, but also plan for the next phase of the activities. Again, these people can also, communities can participate in advertising. Communities can take up advertising of the mass vaccination campaigns to ensure that advertising of the vaccination clinics are done regularly so that people are much aware of the forthcoming campaigns. Community people can participate, registration of dogs during the campaigns, issuance of certificates, restraining dogs, you know, marking of dogs and all that. So apart from that, then we can also look at enforcement. And if we are able to select the right mix of leadership, for example, in the context of Tanzania, there are some leaders that are elected leaders. These people, they enjoy a high level of trust, but also because they are thinking about the next election, when it comes to enforcement of punitive measures for people who don't vaccinate their dogs, you might not really trust them to do a very good job, you know, in enforcing that people actually, people are punished for not vaccinating their dogs. Yeah, so these are some of the things that we can do, strengthening community participation so that they really own the process, and then they are able to heighten awareness, enforce regulations, potentially reduce the cost. Their participation has the potential to reduce some of the cost. If you look at most of the costs that are incurred at the level of the village, if we have strong community participation in the process, some of those costs can be taken out. Then the government or the agencies that are organizing these campaigns, can now channel those funds into more other. But looking at the long term, we need to move towards education. Educating people about dogs and rabies. And that is why I love the initiative by the Tanzanian national strategy for dog vaccination, where they are now seeking to incorporate dog vaccination education into the primary school curriculum. I think that should be encouraged, because we need to move towards a society that takes responsibility for their dogs. Because as it stands now, we find it difficult to even advertise free campaigns. So, and now something that we try to propose. Currently, the government of Tanzania is looking at shifting at least some of the cost to dog owners, which I think in the short term is not going to work. It's a thing for maybe the medium or the long term. But in the long term, we should explore all the avenues, the school system, champions, so that we are looking at a society that is more responsible, for their dogs. And with that, we will, achieve, higher vaccination coverage with less efforts. Thank you.
Thank you, Dr. Tetteh Duamor. I'd just like to go back briefly to your comment about transborder movement. And Dr. Lohr, if you could elaborate on that for just a moment. Thank you.
Yeah, absolutely. I think rabies elimination, if we want to achieve it, we have to really take border or cross-border collaboration into account as well, both on a national or subnational as well as a regional level. So what we've seen, for instance, or where we focus on with our work in Goa is in a very fortunate position that we have a mountain range on the east side. We have the sea on the western side, but we do have some land borders in the north and in the south. And it has been absolutely crucial to engage the neighboring states there to begin with, to also take up mass dog vaccination. And again, the detailed data that we had on both vaccination progress as well as actual rabies cases in the area have really helped to convince the local authorities there. So the vaccination efforts, similar to what is or was happening in Europe as well, with oral rabies vaccinations across borders for wildlife. We have seen that in India between states. So what we have done as well between the states at the state borders, we have provided a lot of info material, big banners. When there are controls, the cars that have dogs are actually checked whether the dog is vaccinated or not. The border agencies have been engaged and sensitized and educated accordingly to check exactly for these details. But also in other places, we're currently working in close collaboration, for instance, between the governments of Zambia, Mozambique, and Malawi to create this closer collaboration, because we have a green border there. Let's face it, there is no border fence, for instance, between the countries. Communities are built across borders, and you wouldn't know if you're in one country or the other in most places. We have to engage the veterinary and the human health services on both sides to align the data and align our activities accordingly in order to stop that spread. Otherwise, we will just continue to re-import the disease from neighboring places, whether that is through free roaming dog movement or through the deliberate movement of animals by people. As we've heard in previous presentation, dogs are inherently linked to people. The easier people move, the easier the dogs move. So focusing our interventions really around those two parameters, not just on human population density, but also the movement connectivity. Dr. Sambo has mentioned pastoralists, for instance, as well. That's also something we have to take into account, the eons-old cultural movement of people across the lands, not just across political borders. When we're planning our campaigns and when we're planning our interventions, very important. And then again, bringing the communities on board and actually providing the information in a way that it is digestible. I think that is the most important bit as well. Not just have a regulation in place and don't police it and don't inform anyone, but actually sensitizing the communities accordingly and making that information easily available and accessible. As I said, for instance, when they go our state borders, they're literally like 5x5 or 15x15 meter placards at the border that you're now entering a rabies controlled area and your dog has to be vaccinated. So, and that is being checked on a regular basis as well when people cross the state borders. So it's very, very important to have that sort of movement control and sensitize the border forces accordingly as well, whether that is like a state border, like for instance in India, or an international border between countries.
Thank you, Dr. Lohr. So if you haven't checked the question and answer box, there's been a request for comment there addressing a large unvaccinated free-roaming dog population when resources are lacking. And Dr. Barassa, could you please comment on that for us?
Yes, I think it's common knowledge that despite the fact that we know rabies is a public health issue of concern, in many of the countries we work in, and when having conversations with the national veterinary authorities, it's always obvious that resource allocation for the prevention and control of rabies as a neglected tropical disease is never prioritized. In fact, anytime governments have to do a supplementary budget review, acts will always target what they call non-priority intervention areas. And the rabies prevention and control measures is always suffering. Nonetheless, communities still recognize this as a challenge, and we as partners who work closely with the communities do acknowledge the resource deficits that governments face. And so in discussing this, I would like to recommend that it requires a significant amount of effort to forge collaboration and partnerships with the different actors. In this sense, of course, not only with the partners, but let me start from the dimension of local authorities. What we do know is that sometimes local authorities, or let me say national veterinary services, have secured the resources to procure vaccines, but lack the resources to facilitate the last mile delivery. And we have seen cases, I don't mention countries here, where vaccines that have been purchased at a very high cost are expiring in stores because they simply lack the resources to facilitate teams who go and carry out vaccinations. So as a suggestion for a way forward, in probably people coming from countries where some little investments or resources have been availed to procure vaccines, investing in supporting the last mile delivery is very key. And not only throwing resources at them, but working collaboratively to create systems, to create structures that sustain the vaccination campaigns for the much longer needed period. I should also say here that we have found it also very useful, for example, in the case of Kenya and also Uganda and Ethiopia, to collaborate with the private veterinarians. Our campaigns in Machakos and Narok and Kajiado, and at one point in Uganda, was very ably supported by private practitioners whom we engaged as service providers and helped us to really achieve a significant amount of coverage with the vaccinations. And of course, sustain this campaign is that typically after these campaigns, if there are some resources, balance of vaccines, then it is given as a donation to them to maintain the continuity of the campaigns during the mop-up exercise. I could also like to say that we have found it very, very useful that in areas sometimes which are classified as rabies hotspots, you may only find one or two actors. But I have to mention here that lobbying and networking and engaging with different charities, foundations, companies, and organizations of like-minded nature have proved very useful. In the case of Kenya, for example, we were doing campaigns funded by BMZ through a project managed by Elly. So when we ran out of resources, we reached out, for example, to Boehringer Ingelheim and engaged in some discussions that yielded very positive results through a donation of vaccines to continue to help us to support these campaigns. So it is not necessarily be expected that governments will do this. Where there is a need and governments are unable to prioritize this as an intervention, and you are an actor in this space, then I think the strategy is to up the game in terms of lobbying and networking to find potential collaborators, well-wishers who are willing to make some donations. Not only free donations, there are also some type of donations which come in form of, for example, subsidies. In the case of Uganda, we were doing a campaign, but we lacked adequate resources to procure the total number of doses that we needed. But we linked up with Zoetis, which is a vaccine manufacturing company, and negotiated a deal of buy one, get two. Now, this helped us to secure quite a number of vaccines, actually double the number of doses we had planned for. It helped us now to scale up the interventions and cover additional areas that were very much in need. I must also say that the issue we have with rabies in the countries is that you talk to health authorities, they think this an animal health or veterinary division problem, you talk to the veterinary division officials, they think that the health people should address this. It's a problem that is neither here nor there. Nobody wants to confront it and address it comprehensively. But I think there is room to engage in a hardcore lobbying and advocacy with the national governments that in their budgeting processes, this is highlighted as a key public health need, that sufficient resources can be invested to support the prevention and control measures that are aligned to the global strategic rabies elimination by 2030. I think that also for communities, sometimes services are available, but communities maybe have got low awareness about the availability of the service, or have an attitude of being able to present their dogs for vaccinations. So getting awareness among communities that rabies is a public health issue, and motivating them to prevent dogs for vaccination through an education program is also very key here. And of course, I also wanted to add that donors, we as NGOs who mainly implement programs funded by donors, we also have challenges that most of the donors in terms of sectoral priorities are not very keen if you just approach that you want to do rabies control as much as a public health issue. But we have in the recent times adopted the One Health approach. This we find quite easy to sell to the donors, and in the recent times we have secured some funding that have components of rabies prevention and control, and I think has worked very well for us. I think those are some of the elements I could have wanted to add at this stage regarding that question.
Thank you very much for those insights, Dr. Barassa. So I'd like to open this next question to all of our panelists and ask you, how important do you see the role of rural communities in terms of rabies transmission? So we have at least some research to indicate that it can cost several US dollars per dog to vaccinate in some very rural areas, particularly Tanzania. So do you recommend focusing on very, very rural communities, or should we be focusing our limited resources on higher density dog communities and target those instead? So Dr. Sambo, I think I saw your hand first, so please go ahead. You have the floor.
Thank you so much. To me, I think the most important thing is to ensure that dog vaccine is available. And the second thing, as Dr. Barassa explained it, if we are using volunteers or community animal health workers, the vaccination cost will be lower, because in Tanzania, the major component of the cost is for buying vaccine, and the second one is to pay per diem to vaccinator. So if we can lower this, if we can lower this cost through maybe donation, or now securing vaccine from our vaccine bank, and also to use volunteers or community animal health or animal workers, so that they can complement the other vaccinators, I think we can much lower the cost per dog vaccinated. And the second thing, I think for me, if we focus much in areas like in rural areas where we are, dog rabies is high endemic, and then there are other like in urban, automatically if we can achieve elimination in rural areas, this, and then automatically even in urban areas or island or coastal areas, the disease can be automatically eliminated. But I'm saying this based on Africa experience, particularly East Africa. Probably in the other area, dog rabies is high endemic in the urban area, but in our community, in sub-Saharan rural rabies is high endemic, and we can focus on it, and in the other areas can disappear. Thank you, Dr. Jerlyn.
Thank you, Dr. Sambo. And Dr. Lohr?
Yeah, thank you very much. I think quite a few points that were touched upon in the previous previous one is, I think when it comes to the overall costs, and Dr. Barassa has slightly touched on this, I think we're focusing very much on the cost of the actual vaccine, but the cost of the actual vaccine is actually the lowest part of the overall cost of delivering of a vaccine into a community. Now, in resource restricted settings, and I think that's what we're talking about in most rabies endemic countries nowadays, we do have to face the reality that we are not living in a Latin American situation where the health services are taking charge and are investing in it, and we do see that we do have the issues with employing enough workforce. Again, community animal health workers, veterinary students would be amazing to use, but we often unfortunately don't have those resources. So what we do have as well is, together with the US CDC and under the leadership of the US CDC, we're currently working on a model called Settlement Type and Road Connectivity, STARC, which actually enables the stratification of an area destined for dog rabies vaccination based on rabies transmission risk. So we can actually, taking all of the local peculiarities into account, we can calculate which areas have the highest risk of rabies transmission, and we can then focus our intervention on these areas as well. So this is a great tool, again, where we don't have like the full power of the Ministry of Finance, the full backing of the Ministry of Finance, which, by the way, should be included in all of the discussions right from the beginning, which I don't think happens a lot as well. But we don't have that sort of backing, and we have to live with what we have at the moment. This sort of focusing on where we can achieve the highest bang for buck, so to speak, might be a good solution in order to target our resources accordingly and use the resources that we have to prevent the largest amount of human rabies deaths and animal rabies deaths. And again, these tools are all publicly and freely available. So.
Thank you. And Dr. Tetteh Duamor?
Yes, just to comment a bit on the possible roles or contributions of communities and the potential that that could contribute to reducing the cost of mass vaccination campaigns, especially considering the activities that happen at the level of the village. And so if you look at right from the planning, advertising, the delivery of the actual campaign, evaluating it and all that, each aspect of it, communities can actually, participate, if not on the entire process, they can participate to a large extent in this process. And that has the potential to reduce the cost of the vaccination activities at the level of the village. But so the challenge I see from my experience is rather working to bring communities on board, because there's a huge opportunity here to reduce the cost of vaccination by, involving communities and thereby, extending the reach of vaccination campaigns. But the challenge is that, especially in the context of Tanzania, or in the context of Tanzania, for example, there's a low priority for mass vaccination at all levels. And so we can look at ways of then motivating communities or community leadership to prioritize mass vaccination campaigns. And one of the ways, or some of the ways, is that we can actually put some of the agreed rules that these people are supposed to play into bylaws or regulations that actually bind them. Or we can convert some of the outputs, rabies outcomes in the community into, some of their KPIs for their routine assignments, so that any positive outcome that is achieved or is recorded in the community with respect to rabies, goes to the credit of the community leader, so that that becomes a motivating factor for them to prioritize dog vaccination. Then also there is the lack of traction for volunteerism. And so that is also something that we need to, so all the time people, are looking at the financial benefits of they getting involved in the work. And yes, if somebody is going to sit at a vaccination center from 8 a.m. to 2 p.m. or 4 p.m., then yes, they should be compensated in a way. But if you look at the history of community participation and the delivery of community-wide interventions, there have been very innovative ways of motivating these people. And some of the ways are not necessarily paying direct money to these people. But then there's also another problem. If you are talking about societies where they have experienced long-standing projects, where people from communities who get involved in these projects, always get paid good monies. And as I see is the case, at least around the Mara region or the Serengeti enclave, where our research team is working. So where you have people who have known these projects and they know how well they pay. So then if you are now, pushing for a more kind of, situation where they work without expecting any direct allowances or allowances that go beyond what they just need to be able to support the clinic on the day, it becomes very difficult. So we have to, it becomes, a situation, an experience that we have to deal with in order to get people, because people are not used to, being paid very good allowances anytime, they volunteer on these projects.
Thank you, Dr. Tetteh Duamor. And Dr. Hiby?
Thanks. I won't add to the excellent contributions by everybody else on the question of cost and efficiency. I thought there was some great answers there. But I did want to just pick up on the question of targeting, and just to say that I wouldn't necessarily use dog density, talking about high dog density as the place to target. I think even in areas with relatively low dog density, we still see consistent R0 of rabies. So we still get that same rabies transmission. Now, my personal opinion of the mechanism behind that is that dogs are social. They'll interact with another dog. If they have to walk 50 meters to do it, if they have to walk 5 kilometers to do it, they will interact. And that's why we get this persistent rabies transmission despite low density. But that's mechanism is my opinion, not tested. But I would say that your targeting should look at where dog and human rabies cases are occurring. And that's how we try to target. Now, you want to look at where these cases are occurring most frequently and target there. Now, that does assume that you've got effective surveillance system in place. And I totally appreciate that takes investment and might not be perfect in all places, but surveillance is an absolute core part of all effective disease control. So it's well worth putting investment into surveillance in order to allow us to target our rabies elimination efforts more efficiently.
Thank you very much, Dr. Hiby. And then Dr. Barassa, a final comment from you before we wrap up this afternoon.
Thank you. I think I just want to have some final reflections on the question of community participation and the element of cost. Of course, for most of the vaccination campaigns we do, service is provided free. And everybody, of course, would like services if they are free to access them. Then the question is, has free services, whenever they are provided, led to a significant increase in turnout or in coverage of the vaccinations? The answer could be yes or no. Now, how then do we balance between participation and cost? In my view, I want to submit that for us to attract a greater participation in these vaccination campaigns by communities, regardless of whether they are free or if there is even some marginal cost to recover from the beneficiaries, then there is the element of added value. I want to submit here that we need to go beyond just injecting the rabies vaccine to the dogs, or even if they are cats. We need to add value, and I will reflect based on some of the recent experiences we have had. We have seen that, of course, when you are planning vaccination campaigns, part of the planning process, of course, involves sensitization of communities and awareness creation around the issues of prevention and control measures. This, if done effectively by whatever means or methodology or modality, is very motivating. People want to learn. People want to acquire more knowledge. People want to understand, what about this? And once that happens, it invites active participation whenever there is a plan to do vaccination, regardless of how you are targeting it. Whether targeting is by door to door, or whether it is decentralized at certain designated vaccination centers. So integrating a strong awareness and sensitization campaign, or let me just say in general, education around this topic of rabies prevention and control is key to solicit interest for participation of communities. But above all, we have seen that every time we are doing a campaign, people present dogs, but then you receive questions about some expected basic services which they could also need as added value services. For example, treatment for basic ailments or some little injuries or some topical wounds which presenting dogs may have, and which owners could want to also be addressed as a holistic package when they present their dogs for vaccination. Other than that, we also see that some younger dogs, especially the young ones, are also presented heavily laden with worms. So if you are doing a campaign and you integrate the worming as part of the service that runs concurrently with the vaccination campaign, then the beneficiaries feel a bit of an enhanced value to the service that you are providing. I saw a comment, people complain about dog population. I think dog population management should be an integral part of sometimes the campaigns that we do, although it's very expensive to plan for. But we have, in our own experiences during our campaigns, provided for capacity to do some limited neutering, either castrations or spaying when requested on a case-by-case basis. Of course, this takes time, is expensive, and is not done for every dog, but if you encounter a request, then you are able to do it. And we find that very useful. By the way, we have also seen cases where you are doing door-to-door and you find in a homestead a very, very sick dog suffering, and really the owner would wish that please put this one down. So euthanasia services can also be integrated in the service. The point here is that it's not just vaccination to prevent rabies, but also addressing comprehensively the welfare need, the healthcare and the welfare need of the dog in a comprehensive manner. Even nail clipping, this is not something that many communities in rural Africa would be keen on. But sometimes if you are doing it at a personal level and as a veterinarian, you may find the need. Then, of course, providing vaccination certificates. We have found a huge interest, pride in providing this to those who are presenting their dogs, going back and carrying a certificate and feeling proud that I've presented mine. I have a record for future reference. And lastly, some feedback sessions. We have found this very useful, that after a campaign, you are doing probably some mop-up, but doing also a final round of feedback sessions with beneficiaries to express either their compliments or complaints about how they felt about the campaign, some issues, some gaps, some challenges, can help you now plan for future campaigns. What do you?
Thank you very much, Dr. Barassa, and thanks to all of our panelists this afternoon. We have covered a lot. There are a lot of barriers to mass dog vaccination campaigns, but we also have presented even more solutions. So a few final comments. If you would like advice about your own dog rabies vaccination program, then please contact our Global Rabies Coordinator, and you can find that email address in the chat. This is also our last webinar for 2023. So please look for more webinars next year, either on the UAR website, or you can sign up for the UAR newsletter, or both. And if there are any particular topics that you wish to see on future webinars, then please be sure to let us know. The dog vaccination document that was presented at the beginning of the webinar by Dr. Hiby is available on the UAR website. And in particular, Dr. Hiby noted that this is intended to be a live document. So there is a link to an online survey, and we'd be very much interested in your opinions. So you can access the link in the chat right now, or you can also go to the document on the UAR website and you can find the link to the survey there as well. And we'd love to hear from you. And finally, there's a UAR photo competition open, so you will also find a link to that posted in the chat. Should you wish to participate, we would love to see your photos. So with that, thanks to all of you for joining this afternoon, and I wish all of you a safe and peaceful end of the year.
Thank you.
Thank you.